I'm Josh Grill. I'm a researcher at the Mary S. Easton Center for Alzheimer's Disease Research at UCLA and a faculty member in the Department of Neurology. I'm here today to talk to you about research into developing new and improved treatments for Alzheimer's disease. What I'll try to do today, before I get to my agenda, if you have questions, please make sure that you ask them using the hashtag UCLAMDChat. Now, what I am going to try to do today is walk through this agenda. I'm going to start by giving some background about Alzheimer's disease, how we currently treat this disease, and then I'm going to spend most of my time on our efforts to try and develop new and improved treatments for Alzheimer's disease. So first, a little bit of background about the disease that we study. Alzheimer's disease is the most common cause of dementia. Now, dementia, by definition, means that a person has problems with memory and one other form of cognition. Other forms of cognition include language skills, executive function, knowing right from wrong, being able to plan the future, and visual spatial function, being able to mentally orient and turn things in our mind, for example, or navigate ourselves through the world. If a person has impairment to memory and one of these other forms of cognition, and those impairments prevent them from living life the way they once did, they meet the criteria for dementia. Overwhelmingly, the most common cause of dementia is, in fact, Alzheimer's disease. Roughly 60% of people who have a dementia that's caused by Alzheimer's disease. And in this country, there are some 4 or 5 million people who suffer from Alzheimer's disease today. Alzheimer's disease is a progressive neurodegenerative disease. It comes on very gradually. Often we can't look back and decide when the disease actually began, when the memory problems first were present. And it remains progressive and gradual through the course of the disease. Ultimately, however, the progression will occur. It may occur at different rates for different people, but this disease is unrelenting, and everyone who suffers from it will eventually need 24-hour-a-day care from a loved one. Now, the number one risk factor for Alzheimer's disease is age. And one of the most common questions we get is, are there more people with Alzheimer's disease than there were 10, 20, 30, 40 years ago? The answer is yes. The reason is that medicine and science have gotten so much better at helping people live to the ages at which we're at risk for Alzheimer's disease. After the age of 65, the risk of getting Alzheimer's disease actually doubles for every 5 years of life. Thus, with more and more people living to be 65, 70, and 75 in this country, we have indeed seen an increase in the number of patients with Alzheimer's disease. What's perhaps most striking about this is that this trend is only going to continue. The baby boom generation has just recently, for the first time, had people turn 65 years old, and more people are reaching the ages in which they're at risk for Alzheimer's disease. So the prevalence of this disease is actually expected to triple in the coming decades. That's obviously very important, and that's obviously the reason that we're working so hard to find better treatments for the people who do suffer from this disease. So currently, there are some FDA-approved medications for Alzheimer's disease. They're listed on this chart. There have been 5 FDA-approved drugs. They exist largely in 2 classes of medications. The first 4 things listed on my chart here are all what we would categorize as cholinesterase inhibitors or acetylcholinesterase inhibitors. These drugs aim to prevent the normal breakdown of a chemical in the brain that brain cells use to communicate with each other. The other class of medication includes only one drug, memantine or Namenda. It works on a different brain chemical, one called glutamate, to try to alter its signaling, especially later in the disease. Now, I said that there have been 5 FDA-approved drugs. All of the drugs on this slide are FDA-approved. Donepezil, or Aricept, is approved in mild, moderate, and severe disease. It's alone in its FDA approval for all 3 stages of the disease: mild, moderate, and severe. The other cholinesterase inhibitors, rivastigmine or Exelon, and galantamine or Razidine, are approved in mild and moderate disease. Memantine or Namenda is approved only in moderate to severe disease. All of these drugs help. When a patient takes these drugs, they perform better on memory and other cognitive tests than they would without those drugs. That's shown in this illustration here that I hope you can see. The pink and the white lines represent a group of people who are taking one of the cholinesterase inhibitors, whereas the black line represents a group getting a placebo. You can see that when people take this drug on a standard memory test, they perform a little better than the group who gets a fake or a placebo that we'll talk about later. When you take away the drug from this group, however, you can see by these gray lines that those patients return to where they would have been without the drug. This means that the effect of this drug is temporary, and that the effect of the drug on the underlying biology of the disease, the natural history of this disease, is minimal, if present at all. You can't tell at the end of this study the difference between the people who got the drug for the first 24 months versus the people who didn't get the drug during that same time. We define these types of treatments then as symptomatic. They help patients deal with their symptoms. Again, a simple schematic to help us understand this principle. With Alzheimer's disease, we expect that over time, a person's performance on a test of memory or other forms of cognition will show decline. That's represented with this dark line here. If a person takes a symptomatic drug, they may experience a mild improvement upon starting that treatment, but over time, the rate at which the disease progresses is unaltered. The slope of this orange line is the same as the slope of the dark line representing the underlying disease. Our field is extremely focused now on developing a different type of drug, that is, a disease-modifying therapy. The green line represents what we hope the next generation of AD therapies will be able to do. That is, slow the course of the underlying disease, slow the progression clinically that we observe in people with dementia. We may sacrifice that initial symptomatic bump with these new treatments, but over time, you can see that the benefit is substantial. That is, later on in the disease, the patient is performing much better on cognitive tests than they would be if they got no drug at all, or if they got a symptomatic therapy during that time. Also, if we were to take away the drug that's represented by this green line, it would not, as we saw in the earlier slide, return to the black line. Instead, that line would simply turn and assume the same slope as the black line, but the underlying biology of disease would forever be altered, and the patient would forever have benefited from receiving that therapy. Now, of course, it's also true that with these new drugs, it'll be even more important to start therapies as early as possible, rescuing as much cognitive function as we can. So how are we going to develop these new drugs, these disease-slowing therapies? Well, much of our research now goes back all the way to Dr. Alzheimer. Alois Alzheimer first characterized this disease that would later take on his name more than 100 years ago. He followed one patient, August D. He followed her, demonstrating her symptoms, characterizing her clinical phenomenology, and then, when she passed away, examining her brain tissue. Even 100 years ago, he was able to see in her brain two things that did not belong there. We still study those two very same things today. They are, one, the amyloid plaque, or neuritic plaque, and two, the neurofibrillary tangle. Neuritic plaques are composed of an abnormal protein called beta amyloid. This protein is present in high levels in patients with Alzheimer's disease, very low levels in people who do not have Alzheimer's disease. One of the things that makes this protein abnormal is that it's very sticky, and the thing that it sticks to the most is itself. So it actually accumulates in these plaques that exist in between brain cells, interrupting the way brain cells like to talk to each other. This may eventually lead to the formation of the neurofibrillary tangles. Tangles, again, are composed of a protein. It's a normal protein that exists in all brain cells called tau, but it is overprocessed in Alzheimer's disease, causing it to condense upon itself again, this time inside the brain cell, and interrupting the way the brain cell functions, and ultimately, we think, probably causing that cell to die. So though Alzheimer first characterized plaques and tangles, thankfully, 100 years later, we know a great deal more about these proteins and about what they do in this disease. So in the last couple decades especially, we've made tremendous strides towards understanding more about Alzheimer's disease, its causes, who it happens in and who it doesn't, what the biological changes are that occur during this disease, and hopefully how we can intervene. This slide lists just some of the hallmark new learnings that we've made in the recent decades. We've isolated the beta amyloid protein and even crystallized it. We've identified genetic mutations that cause a very rare form of Alzheimer's disease. This form has an early age of onset in the 40s, 50s, and 60s. It is purely genetic, making it very unique to the form of Alzheimer's disease that we typically think of, starting in the 60s, 70s, and 80s. The genes have been identified. They occur in families, so only people who have a family history of this specific form of the disease are at risk for it themselves. We actually study these families here at UCLA, and three genes that can be mutated all are involved in the production of beta amyloid protein. Though these families only account for 1 or 2% of all patients with Alzheimer's disease, they've been highly instructive in helping us learn about the disease. These three genes can be mutated in the laboratory and used to model in cells and in animals what is happening in the disease, and have rapidly advanced our understanding of Alzheimer's disease as well as the development of new treatments for it. We have, however, also identified genetic risks for the other form of Alzheimer's disease, the 98% of people who have a later age of onset form of this disease. These genes, however, are not predictive the way the other ones are. These are simply risk genes. These genes may ultimately be very instructive in predicting who will get Alzheimer's disease or helping us to develop or identify who will benefit from new treatments. However, at this time, they are not so far along. We've also seen great advances in our understanding of the biology of the disease and have then used that knowledge to develop what we call biomarkers, measures of the disease in people who are still alive. Alzheimer had to examine the brain of August D. after she passed away. We now have mechanisms to examine the biology of the brain and the central nervous system while people are still alive. Here too, rapidly advancing the rate at which we can learn about this disease. This next slide is overly complicated. It's meant to represent the cellular and molecular changes that occur during Alzheimer's disease. I'm not going to leave it up very long. It's only to show that by learning all of these different steps, we have also developed ways to potentially intervene and stop what's happening, or at least slow what's happening biologically in the brain of someone with Alzheimer's disease. Some of the treatments that are being developed based on this knowledge that are very exciting and hold great promise include treatments that can actually prevent the formation of the amyloid protein that accumulates in the plaques. Other treatments can actually pull the beta amyloid protein out of the brain, reducing the plaque burden on the brain itself. And we have new treatments coming along that are targeting the neurofibrillary tangles, and specifically the tau protein and the overprocessing of that protein by preventing the overprocessing or reversing the effects of that overprocessing. Even if all of these strategies fail, an alternative strategy is to simply try to protect the brain cells and the connections between those brain cells that we call synapses, so that a person can continue functioning normally despite the accumulating pathology of the disease. So many promising strategies, many of which we're still studying today. One that I'll highlight because I think it's fascinating is a new strategy called immunotherapies. A vaccine was tested more than a decade ago. It demonstrated preliminary results that were somewhat promising, though there was caution required in interpreting them. That vaccine study has launched several subsequent studies of new vaccines and studies of, like I'm showing here, what are called antibodies. The body's natural defense system, the immune system, responds to invaders, and these treatments aim to capitalize on the immune system to try to better fight against the plaques and the tangles. In this case, I'm showing you data from a study of a monoclonal antibody, meaning it recognizes its A-beta targeted in only one place. And these images are specifically from PET scans that show us the amount of beta amyloid in the brain. This PET technology was recently FDA approved. And you can see in this slide, and I'm going to start on the bottom, that in a patient who participates in this study for 18 months but receives placebo, shows a small increase in the amount of beta amyloid present, measured here as the red signal on the PET scan, showing us the amount of plaques. For two patients, patient 1 and patient 2, who got a placebo, we see this increase in the plaque burden over the course of a year and a half. Alternatively, in patients who received a monoclonal antibody against the A-beta protein, we actually see a reduction from baseline to a year and a half later as a result of treatment. Similarly, here in this patient, we see a reduction from baseline to almost no signal present at all for the amyloid protein on this PET scan. So very promising and indeed very exciting. So why can't we simply take this drug and get it to all of the Alzheimer's patients, as I've told you, 4 or 5 million in this country alone, who so desperately want better treatments? The reason is that we're not there yet. These drugs have not yet been proven to be safe, and they have not yet been proven to be effective. And the way that we determine whether or not a new treatment is indeed safe and effective is through particular rigorous studies called clinical trials. And I'm going to talk about clinical trials now. A clinical trial is, in all honesty, an experiment that enrolls human beings. It must be prospective, that is, it must move forward. It's not adequate to look back and say someone got a treatment and seemed to do better. We must begin a study by moving forward. Clinical trials must include a control group. There must be some form of comparison. Ultimately, what we're doing is we're saying, is a drug better than a control? Is it safe relative to the control, and is it more effective than some control group? The goal of a clinical trial is to answer a scientific question. The most important thing with each new clinical trial is that we achieve that goal, that we answer a scientific question. And importantly, clinical trials are not clinical care, nor are they required by your doctor. Participation in a clinical trial is always voluntary. Even if your doctor is also an investigator in doing the clinical trial, you should be aware that you are not obligated to do it, even if it's something that they recommend. Many people credit James Lind on the voyage of the Salisbury as one of the first, or at least earliest, best documented clinical trials. He had 12 patients aboard this voyage who developed scurvy. He assigned each of them to a group, it turned out 6 groups, of different treatments, and then followed them to see how they did. He observed that of the 2 people he assigned to lemons and oranges, one by far responded the best and was actually back to work on the ship within 6 days. The second responded better than any of the other 10, and that person was actually assigned to be the nurse. This is often credited as one of the first clinical trials, and it really does demonstrate some of the rigorous things that we still use today. There were multiple groups, there were groups to compare, there were controls, and we may assume that Mr. Lind, Dr. Lind, randomly assigned each person to one of those groups. Why are clinical trials so important? Simply put, without clinical trials, we don't have new medications. If any of you watching online right now have ever taken a drug, you are the beneficiary of rigorous clinical trials. The only way the FDA approves new treatments is when they are demonstrated to be safe and effective through clinical trials. We often hear about phase 1, phase 2, and phase 3 clinical trials. I'll briefly describe these. Phase 1 clinical trials are when we have a promising new molecular entity or a new drug that's been developed in a laboratory, and for the first time, we give it to human beings. These are usually done on healthy, young control participants. The objective is overwhelmingly safety. We want to know if we can give this drug to humans safely, and oftentimes we want to know how much of the drug we can give safely. So we will do what's called an ascending dose study, trying to determine how much of the drug we can give before problems begin. If those studies go well and the drug is indeed safe, we can move into phase 2 clinical trials. Often the first trials in the patients we aim to help, that is the people who suffer from the disease that we hope the drug will someday be approved for. In our case, first time we give a drug to Alzheimer's patients. These two are somewhat small studies. Again, the goal is safety. Can we give this drug safely to the patients we want to help? We also begin to look at effectiveness, more so for the point of wanting to be able to design future trials that will be adequately powered. That is, will enroll enough people to statistically show us whether or not the drug is effective. That occurs in phase 3 clinical trials. In Alzheimer's disease, phase 3 clinical trials often make news media. They're reported in the lay press. They're very large, very difficult, and very expensive trials. Most of our current phase 3 clinical trials will enroll at least 1,000 patients and will be at least 18 months long. So they're very challenging studies. They are, however, the studies that result in FDA approval. The FDA requires not one, but 2 successful demonstrations of drug efficacy and safety in phase 3 clinical trials. The basic design of a clinical trial looks something like this. We have people sign an informed consent. They are determined whether to be eligible for the study or not. If they are randomly assigned to one of at least 2 groups, followed for some period of time, and then we measure something. That something could be safety, that something could be efficacy, and we will compare the treatment to the control to determine the outcome of the study. So a bit about each of these parts. Informed consent is critical for anyone who is themselves or has a loved one considering whether to participate in a clinical trial. An informed consent is a legal and ethical document that describes the study in great detail. All of the procedures, all of the processes, all of the visits, the number of visits, the length of the study, everything must be described in this document. It also must describe the risks and discomforts that are possible or even likely to happen during the study. The point here is to make sure that people understand what they're getting themselves into when they agree to participate in a clinical trial. These documents should be given with free will by the investigator, and there should be no obligation to sign them right away. In fact, you should be told that you can take this document home with you, sleep on it, talk to your own doctor, talk to your family, talk to anyone you would like to before making the decision whether or not you want to be in a clinical trial. Informed consent does not bind a participant. I said that clinical trials are always voluntary. Even after signing an informed consent and agreeing to be in a study, it remains a voluntary process. You can choose to withdraw your consent or stop participating at any time that you would like. We always make clear to our participants in clinical trials that you can choose to stop taking a drug without choosing to stop being in the study. In fact, people who want to stop taking a drug because it causes some side effect that they're not comfortable with or for any other reason can provide extremely valuable data to that clinical trial by continuing to participate for the duration of the study. And an informed consent, it does not make a clinical trial ethical. It's up to the researchers and several regulatory bodies that oversee clinical trials to indeed ensure that our studies are ethical. In Alzheimer's disease, we deal with a disease that, by definition, affects our ability to make decisions, affects brain function, and not all Alzheimer's patients will be capable of making the decision whether they want to participate in a clinical trial. That is called capacity. Now, importantly, capacity is not an all or none phenomenon. Many Alzheimer's patients maintain the capacity to make most decisions throughout their daily life, but they may not, for example, maintain the capacity to make the decision whether to participate in a clinical trial of something like a monoclonal antibody against the beta amyloid protein. So that assessment of whether an individual maintains the capacity to provide informed consent must be made by the investigator at the time of the initiation of the study, at the time of the informed consent. Now, if the person does not have the capacity to provide the provide their own informed consent, there are ways to continue participating in studies. Of course, because this disease affects the decision-making properties, it's critical that we still be able to do studies on people who don't necessarily have that decision-making ability. In California, the path is laid out very straightforwardly of who can sign on behalf of their loved one, and we handle that, of course, with each new discussion with participants. Now, it is important to know that even if a person does not have the capacity to make the decision to participate themselves and a loved one signs on their behalf, we still must assure that the participant, the patient with Alzheimer's disease, provides what's called assent. They are going to agree that they want to be in the study. If they don't agree to be in the study, then they simply cannot be enrolled. So once a person does sign an informed consent and they begin the study, the first research procedure is to determine whether or not that individual is eligible to be in the trial. That is, do they meet inclusion criteria without demonstrating any exclusion criteria? This is critical for our trials for a number of reasons. First, we want to ensure that we only enroll people safely. So if a person has, for example, had a stroke that causes memory problems, there could be increased risk for them participating in this drug trial. It's also true that if that person had a stroke, that could cause their memory problems, and a drug that helps Alzheimer's disease might not help them. And so our ability to answer our scientific question, does this drug help people with Alzheimer's disease, could be impaired by enrolling that person. So we're very careful about who gets to participate in clinical trials. People must also meet inclusion criteria. These are a little bit more straightforward. They include things like a diagnosis of Alzheimer's disease, scores on standardized tests, and age, for example. Now, unfortunately, the reality for us as researchers doing clinical trials in Alzheimer's disease is that a very large proportion of patients will actually be deemed ineligible for studies. We said there are 4 or 5 million people who suffer from this disease nationally. You'd think it'd be easy for us to do clinical trials, but it really often is not. We last year published a paper that suggested upwards of 75% of Alzheimer's patients will be deemed ineligible for clinical trials. And other groups other papers by some of our colleagues have suggested that rate of exclusion is even higher. Throw in the fact that not all patients and their families are aware of clinical trials, and many choose not to participate if they are, and you can see that we are up against a very challenging scenario of enrolling people in these sometimes very large clinical trials that aim to put more than 1,000 patients into our studies. That said, we ultimately hope to enroll enough patients to be able to answer our scientific question. If a patient is found to be eligible, then we will randomly assign them to one of 2 or more groups, a control group versus an active treatment group. Randomization means that everyone who participates in this study has an equal chance of being assigned to each group. It's a pretty straightforward thing. The point here is to remove bias. If we put the first half of people who enrolled into a trial into one group and the second half of people who enrolled into a trial in another group, then, for example, what if something happened during that time of the transition that really changed the way we understood this disease, or we found that some dietary component could be used to slow the course of the disease? Then the group that was enrolled after that change could look different from the group enrolled before. So we must minimize every potential external bias, and randomization is the best way to try to do this. Successful randomization will look something like this. This is from a paper describing a clinical trial of the Chinese herb huperzine in patients with mild to moderate dementia. The point here is that there were 3 groups: placebo group, low-dose huperzine, and high-dose huperzine. We've got several demographic factors listed here, and across the groups we can see that they are extremely similar. This is demonstration of successful randomization. The average age of the people in each group is about the same. The number of females in each group is about the same. The baseline scores on cognitive tests are about the same. Thus, if we see differences at the end of the study between the groups, we can largely assume that those differences are due to the group assignment, not due to any other inherent differences between those groups. That's the point of successful randomization. We also will perform our studies blinded. Now, I've defined single and double blind here, but most of our clinical trials will be double blind, meaning that the patient participating does not know if they're getting drug or placebo, and the investigator giving the drug also does not know if the patient is getting drug or placebo. Here, too, the objective is to minimize bias. It's human nature to want these drugs to work either in ourselves or in our patients. And to minimize that bias, we prevent us from knowing which group an individual has been assigned to. Our clinical trials face many barriers, and this is perhaps more true for Alzheimer's disease than for even other areas of medicine. I like to make clear the difference between a failed drug and a failed clinical trial. A failed drug is one that does not help or is not safe. We know that drugs fail through successful clinical trials. If a well-designed, well-run clinical trial shows us that a drug is no better than placebo at helping Alzheimer's disease, the trial succeeded, the drug failed. That's an unfortunate reality, but a necessary one. The unacceptable outcome is a trial that doesn't answer its question. That's a failed trial. If a trial doesn't show us whether or not a drug is better than placebo, the trial has failed. Failed trials are the only way that we don't move forward. Successful trials propel our understanding, our knowledge further and further and closer to our goals. So it is essential that each clinical trial succeed. Now, there are barriers to success. I already alluded to the fact that it is very difficult to get enough patients to participate in clinical trials. Many are excluded. The reasons for exclusion include that older patients are more likely to take many drugs, and some of those drugs may preclude their being enrolled. Older patients have comorbidities, and some of those comorbidities, like stroke, can prevent someone from being enrolled. We also know that most patients aren't aware that clinical trials are even going on. Primary care physicians more commonly are diagnosing this disease, and even they don't know of all the local clinical trials because they've got a lot on their plate. So we need to do a better job of getting the word out through mechanisms like this one and others so that patients who have a diagnosis of Alzheimer's disease are aware of the opportunities to participate in clinical trials. Slow enrolling trials actually face great challenges, and some studies suggest that the slower the enrollment for a study, the less likely it is to demonstrate a benefit of treatment. Also, in our clinical trials in Alzheimer's disease, we require not one, but two people to participate. The patient with Alzheimer's disease must obviously participate, but they also must have what's called a study partner. This is a person who's going to accompany them to visits and will sign informed consent themselves because they have a role in the research study. We often will ask them questions about how the patient's doing and ask them to assess things like functional abilities around the house or in their life otherwise. Another barrier in our clinical trials is that the people that we enroll often don't look like the general population who suffers from Alzheimer's disease. To demonstrate this, I'm showing some data from two different studies. First, a study called the ADAMS study, which is a community-based cohort recruited straight from the community, meant to represent the general population in a few different areas of our country. Next to that, I'm showing data from one clinical trial of the omega-3 fatty acid fish oil run by the Alzheimer's Disease Cooperative Study. You can see that as we work down our demographic categories here, that the clinical trial population differs significantly from the community-based population. The participants are younger, they're more often non-Hispanic Caucasians, they have higher education, and in our trials, they all participate with a spouse, even though most Alzheimer's patients actually don't have a spouse. I'll delve a little further into this. This is a paper we published last year looking at 6 different clinical trials run by that same group, the Alzheimer's Disease Cooperative Study, and looking at the type of study partner that a person enrolled with. Again, the majority of Alzheimer's patients don't have a spouse. Yet when we look at who participates in clinical trials, 2/3 of patients enroll with a spousal study partner. This is important because there's a great population of people with Alzheimer's disease out there who aren't participating in clinical trials. And so we could answer our questions faster if we can get more of those patients to enroll in our studies. And that probably means making their family members aware of our studies and seeing if they want to be a part of them as well. I also mentioned the difference in race and ethnicity. One study looked back at a 10-year history of Alzheimer's disease clinical trials and showed that 90% of participants in NIH-sponsored trials and 97% of participants in industry-sponsored trials were Caucasians, non-Latino Caucasians. So that means that African Americans, Latinos, Asians, these are all people who are being left out of our clinical trials. To some extent, this is important because we could expedite drug development if we could get more people to participate, but it's also important to note that in other areas of medicine, observations have been made that led to drugs being approved in specific races. If a drug came along that worked in any of the races or ethnicities I mentioned, but did not work in non-Latino Caucasians, we simply would not know it because not enough people of different races and ethnicities participate in our clinical trials. So there too is something that we must get better at. Lastly, a few words about retention. When someone enrolls in a clinical trial, it's fantastic. We are extremely grateful. They are part of our research team. We're proud to work with them to try to learn more about this disease and to find better treatments. Enrolling, however, is only the beginning. And what is ultimately most important is finishing the clinical trial. If people drop out of a clinical trial, it can leave that trial underpowered statistically to answer its scientific question. And so, again, clinical trials are always voluntary. You're always free to choose to stop participating in a study. However, as an investigator, it's our job to enroll people who we think are most likely to finish the study because that's the only way that we answer our scientific question. And we looked at several clinical trials and showed that many clinical trials actually have lower retention rates than they were planned to have. And so those trials could have been statistically underpowered. So it's important that someone who's considering participating in a clinical trial take the decision very seriously because only by enrolling and finishing the trial can we answer scientific questions. And again, we never ask someone to do something they don't want to do or to put themselves at risk simply for the sake of answering our scientific question, but we have alternatives like stopping the medication and still completing the trial that can help us with that. So clinical trials are probably not for everyone. And again, that decision is one that should be made in consultation with many professionals, your family, and investigators. And only then should you choose to enroll in a trial if you think it's right for you, if you trust the person who is running the study, and if your family agrees. And only by people doing that will we get more answers to our scientific questions. Now, importantly, I've focused entirely on the development of drugs and clinical trials that are studies to help with the development of those drugs today. At UCLA and at the Easton Center, we have many different types of studies that are going on today. That includes studies that have really minimal involvement, like hour-long interviews. We have a study of an hour-long interview going on right now. That is the sum total of participation. Alternatively, we have other studies like neuropsychological testing studies, neuroimaging studies, and longitudinal clinical studies that run the gamut in the amount of involvement associated with those studies. Many involve a single visit once a year where you meet with a neurologist, maybe have some memory testing, maybe have a blood test, perhaps an MRI. And we really have many different types of studies beyond just studies of new medications. So to summarize, clinical trials are rigorous scientific studies that aim to answer a scientific question and must do so for us to develop new and improved treatments for Alzheimer's disease. These studies are always voluntary and they always need more participants. That's true for Alzheimer's disease as well as every other area of medicine. In Alzheimer's disease, we have many exciting therapies that we are testing, and we hope very much that they will yield the results that we all so desperately want, drugs that can actually slow or stop the course of Alzheimer's disease. Unless something is demonstrated to be safe and effective in clinical trials, however, we simply cannot recommend its use. If you're interested in resources about clinical trials or about other types of studies, I would urge you to call or take a look at the website for the Mary S. Easton Center for Alzheimer's Disease Research at UCLA. That website is here, www.eastonad.ucla.edu. And if you have questions right now, I would refer you again to the hashtag. I believe it's UCLAMDChat. Sorry? MDChat. Okay, and with that, I'm going to turn my attention to the questions that have already come in. So the first is, which current research clinical trials look promising? We only take on trials at UCLA that we hope are promising. If we didn't think a drug looked promising, we simply wouldn't start it. We try to keep a list of the clinical trials that we're doing on our website, the eastonad.ucla.edu. And all of those studies I would categorize as promising. If a drug does not hold promise, or if we think it's not likely to yield important results, we simply won't take on that study. So I think that there are many treatments that hold great promise, but only by completing these trials will we really have the type of information that we need. The next question is, are there any clinical trials that don't use a placebo group? There are sometimes what we call open label studies. That is, it's meant to be a study where everyone gets some new treatment or some old treatment, and we follow them to see what the results of that treatment are. These are less rigorous studies, admittedly. Another potential outcome is that many clinical trials that are placebo-controlled will have a blinded portion of the study, be it 12 or 18 months, and then an extension study in which there is no placebo. That too is referred to as an open label extension, and that is fairly common, especially in clinical trials sponsored by pharmaceutical companies that hope to gain FDA approval for that treatment. The next question is, are clinical trials in Alzheimer's disease happening closer to my home in Santa Clarita? And if so, why participate at UCLA? Well, yes, clinical trials are happening all over Los Angeles, all over the United States, and all over the world. And that certainly includes clinical trials for Alzheimer's disease in all of those areas. You should participate in a clinical trial wherever is most convenient to you, where you're most likely to be able to finish the study, and where you find investigators that you feel you can trust and have your best interests at heart. And that's a decision that only you can make. Okay, what if I'm in a clinical trial and something goes wrong? Well, there are no promises in clinical trials. Things can go wrong sometimes, although these incidents are rare. If, however, something goes wrong and you're participating in a clinical trial at UCLA, we're going to take care of you. That's in all of our informed consents. We're going to provide your care. It's always going to be free of cost. I should have mentioned that participating in clinical trials is always free of cost when you participate in an Alzheimer's disease clinical trial with us. There are no charges for being in a clinical trial, although it's very rare that there's any form of payment for participating in a clinical trial. Okay. I am waiting. I think I touched something there. That's good. Thanks. How long before there is a new drug that can slow Alzheimer's disease? That's an important question that we all want to know the answer to. There are some drugs that are currently in phase 3 development. We're about to start a new phase 3 clinical trial of a drug that demonstrated some promise in previous phase 3 clinical trials. So the previous phase 3 trials failed. They did not show the drug was safe and effective. The drug certainly seemed safe, but it wasn't effective in all the participants. The trial's being repeated only in participants who seemed to benefit in the earlier study. Even if that trial succeeds, however, we're still at least 2 or 3 years away from it being approved. And the likelihood is that we're at least 2 or 3 years away from any drug being FDA approved. I'd love to be proven wrong on that statement, but that's my honest opinion right now. Okay, and then the last question. Why should I participate in a clinical trial? Well, I've had discussions with many people who do choose to participate in clinical trials and ask them why they made that decision. There's many terms used in fields of study of this question specifically, but the one that is my favorite is called conditional altruism. Many people participate in clinical trials because they're altruistic. They want to help mankind, they want to help science, they want to help future generations. Other people participate because they want to benefit. They want access to a treatment that's not yet available, and the only way to get it is by participating in a clinical trial. The majority of people, I think, fit into both of those categories, and the term I like from literature is conditional altruism. I really want to help, but I sure hope I get something out of it too. We partner with a lot of those people. We need to partner with more people like that, because only together will we be able to develop better treatments and make a difference in the problem that faces our society in the form of Alzheimer's disease. I hope you've enjoyed this session. I've enjoyed delivering this lecture to you. Please tune in again for future sessions on this web channel, and thanks very much for your attention.